Welcome, everybody. Thank you for joining us for our MFP Tuesday trainings. Today we have Annette Weigel and Christy Clark presenting on home and community-based services. And just a couple of housekeeping. Please remember to keep your microphones on mute and your cameras off for the presentation. And if you have any questions, please put them in the chat and then we will relay them to the presenters. I think that is it. So we'll go ahead with Christy and Annette.
Okay. Hi, I'm Annette Weigel. I'm one of the program administrators with Home and Community-Based Services. And in just kind of a nutshell, we have about 75 case managers, all social workers out across the state doing social work for home and community-based services. And Christy, I'll let you introduce yourself.
Yeah, my name is Christy Clark. I'm also a program administrator under Aging Adult Services, focusing on home and community-based services, HCBS. Just want to make sure you can see this PowerPoint screen that I'm sharing. Annette, can you see this okay?
Yes. Yep.
Yes.
I
Okay,
can.
perfect.
Yep. All right. So we want this to be informal, so please ask questions as they come up. And we just wanted to give an overview of what services we can provide under home and community-based services with adult and aging services. So really what our programs do is we kind of wrap around services depending on what the person needs and qualifies for to keep them in a home environment if that's their choice for as long as possible. And we have different funding sources. Medicaid would be kind of the highest level of funding that we could access, and we have to do that if somebody's eligible for those federal funds. And then we are one of only a few states who also have state funds, which is SPED, and that stands for Service Payments to Elderly and Disabled, and XSPED, which is kind of, Christy will get into that a little more in the details of the difference of those two. So our legislature for many, many years has continued to support those state funds for people who don't qualify for Medicaid, but still need some help in their home. One of the differences is that our programs serve people who are primarily physically disabled, so anybody over the age of 18, and either physically disabled or elderly. We can serve some people in a very limited capacity who have primarily mental health diagnoses, but that is not the norm. Our services really are not intended to provide for that population. And the other population that we are not able to provide for is people who primarily have an intellectual disability, for instance, Down syndrome, as those are all other agencies providing those services. So recipients that we serve, they have to meet financial eligibility and functional. And functional means what are you able to do for yourself? What do you need help with? Sometimes we will get people who say, well, but my mom has this diagnosis, right? Our programs don't really go by diagnosis as far as eligibility, but more functional. What are you able to do? What aren't you able to do? The other thing is if somebody's on Medicaid, they might have a recipient liability or a cost share that could go towards their services, would need to be paid. And under the SPED program, it is based on assets, but also on income. And so they may have a cost share based on what their income is as well. How referrals generally come in, we have an intake line called ADRL, and people call in and say, my mom needs help. If you're a landlord, you may see somebody who needs help. You can call in with a referral. The intake specialist will call the individual and do a general assessment of their needs, just to make sure they meet basic criteria to move it forward. And once it's moved forward, it gets assigned to one of our social workers who goes out and does the assessment. And again, it is based on individual needs. So, for instance, if somebody would like assistance with cleaning or laundry or shopping, but they are able to do those, we are not able to do that for them. There has to be the need there. The individual runs the show. They have the choice of services and the choice of providers. So we may go in and see that John really could use help with bathing. It appears he hasn't bathed for a long time, and we talk to him and would like him to do that, but it is his choice of what services to accept. Also, the case managers are not the providers of these services. So all of the providers throughout the state are self-employed. They have their own companies, or they're an individual provider. It might be a family member as a provider. And the individual chooses who they want. So the case manager can help facilitate that by looking for a provider for the person, but the individual themselves chooses who that would be. Our goal, again, is to maintain as much independence as possible in the least restrictive setting. And if somebody chooses to go to a facility, and that is their choice, and we are completely supportive of that as well. Our programs just give another alternative to institutionalization. Um, Okay, the first bullet kind of says what we talked about, that we want them to be independent in the community if they're able to. Some people we have that we serve might need 24-hour care at home, and we are able to provide that depending on where in the state that person lives. Of course, the rural areas, it's much more difficult because providers generally do not want to go out to that area. Um, Sometimes that's, to provide that high level of care. And so that does make a difference. Um, Other times we have people who maybe only once a week receive some homemaker cleaning and laundry help. Um, and there are situations where if it does become no longer safe, or the person's needs can't be met in that situation, we may not be able to continue to provide those services as well. So really the role of the social worker is to go out, assess, and then once services are set up, to continue to monitor, make changes. Really, we want to give people all the options available, and um, even available in addition to home and community-based services, available throughout their community. So even though we may not cover certain things, we can give them, resources, public health or the senior center for meals. And so we're making a lot of referrals, as well as authorizing the services that we can cover. Um, Yeah, so Christy is going to take it from here with kind of going over what the primary funding sources are, and then what services can be covered under each funding source.
Yeah, so some of this will be just a little bit of like a high level overview, but we can talk about specifics if we need to. It's kind of just dependent on what everybody's interested in. And feel free to have, if you have questions, if you want to unmute yourself, you can certainly interrupt us as we're speaking. We can answer questions. I am so used to using Microsoft Teams. I am not used to using Zoom. And so I might not notice that there's like a chat or something. So Cheryl or somebody else, if you guys notice something, feel free to interrupt and let us know if anybody has any questions. So just like Annette was talking about, we have different services and funding sources that our case managers are able to authorize within our realm of aging services, HCBS. So we kind of separate these into four different categories. There's just so many services. It kind of helps to think about it this way to kind of organize in our mind how everything lies out. So that's how we structured the PowerPoint for you. So over here, kind of on the left, we talk about our service payments for the elderly or disabled, SPED, and I think we'll talk about that first. We also have another funding source named Expanded Service Payments for the Elderly and Disabled, or XSPED. We have to shorten these names up because they're kind of a mouthful. Then we have Medicaid State Plan Personal Care and the HCBS waiver. So those are kind of like the four funding sources that we focus on. As a side note, under the umbrella of aging and adult services, we do also have basic care case managers. And those case managers actually provide the functional review and make sure individuals are eligible and manage the cases for individuals who live within basic care. So, kind of a side note. And then, as part of that basic care eligibility function, Medicaid eligibility manages the room and board payments. So again, kind of we're going to focus on these four key services in terms of the different funding source structures. So we'll talk about SPED first. So SPED. So SPED is a state-funded service. When we look at whether or not an individual qualifies for the funding source of SPED, we do have to do that overall functional assessment. So like Annette was talking about, our case managers meet individually with every person who's interested in services, and they really do a comprehensive assessment with them to determine what areas are they impaired with, what areas are they maybe independent with, and what areas do they kind of struggle with, but they're able to manage on their own with like use of equipment. So in order to functionally qualify, like physically qualify for this particular funding source, we look at activities of daily living. So those would be things like, bathing, dressing, transferring, kind of in that type of realm. And an individual to qualify would either have to be impaired in two of those activities of daily living, or if not, they would have to be impaired in four instrumental activities of daily living. And those are different things like meal prep, homemaker, money management, those types of kind of like higher level skills. So they kind of work on a point system. We have a whole Barthel scale that we utilize in order to make sure we're doing consistent scoring, whether an individual is functionally eligible or not. So just know we kind of look at their ADLs and IADLs to see where they fit for eligibility. It's a long-term service. So like all of our services are designed to be for individuals who have had an impairment for at least 3 months, or they're expected to have an impairment for at least 3 months. So it's not like a short term, like acute care, a person who's completely independent, but maybe like breaks their leg or something like this and needs very short-term services. It's really for those individuals who have long-term disabilities. For this particular funding source, we're not able to tap into this funding source if the primary impairment is due to mental health or developmental diagnosis, intellectual disability. Like Annette was saying, we have other funding sources for those types of needs. This is more primarily like that physical disability component. Um, and then again, this is funded by state dollars. And so if an individual qualifies for a different funding source that we'll talk about later on, where we can use Medicaid dollars, we're going to use the Medicaid dollars before we can tap into SPED. So that's just kind of a caveat to keep in mind here. So again, our case managers complete a functional assessment, but they also have to complete a financial assessment for SPED. SPED is our only funding source that we have available where a person doesn't have to be on Medicaid. So because we don't have Medicaid eligibility involved, we kind of have to do our own financial assessment. Important to know that a person's assets cannot be over $50,000. If they're in that bracket, then they would not be eligible for any type of SPED assistance. Um, what we do is we work on a sliding fee scale basis. So the case manager gathers information about their assets, they gather information about their income, any deductions they might have, and they might fall within a sliding fee scale. So some individuals might pay nothing for their services. Some individuals might have to pay 10% of their cost for services, 20%, 30%, all the way up to 90%, just depending on where they're at within the assets and income. And so that's what we mean when we say you may have like a SPED fee or a client cost share. So maybe if you have a fee of 10%, SPED's going to take care of paying 90% of your services, and you're going to be responsible for paying that other 10%. So it's kind of how we do it. This is a lower level service. This is not a Medicaid dependent service. So an individual, in terms of like the amount of services they can get each month, like how much we can provide each month, we can't pay more than about $4,000 each month. Right now, it's exactly 4,112. It changes a little bit each fiscal year, but this is not the type of service that's going to pay for like 24/7 care, like a higher level need type of an individual. Okay. So again, we kind of already talked about this. We have a sliding fee scale. We don't need to get too into this, but if we have an individual who's kind of off the charts of the sliding fee scale, meaning their income puts them at 100% fee, then they would not be eligible for SPED services. Okay. We have just a variety of services under each funding source. We're kind of unique in that manner where an individual could potentially have multiple services kind of combined, put together. So I just wanted to kind of point out maybe some of the more generally used ones here. You may see individuals who have like a family member living with them and they're paid, that family member is paid to provide care to them. That's pretty common. We have family home care, which is a service that helps pay to care for your loved one in the home. We might have an individual who's on homemaker services, so they could receive support with like laundry, shopping, housekeeping, those types of tasks. If they're not eligible for Medicaid, they cannot get on Medicaid personal care services. We are able to authorize some personal care under SPED. And then there may be individuals who, well, we have a lot of individuals actually who have an emergency response system, like a life alert button. That's pretty common. And then, sometimes we're able to provide like some nursing services under this program. That's primarily under our waiver program. But for individuals who have a lower level of need, it can potentially fall under this funding source. And then we do see home delivered meals authorized quite a bit as well. So some of our clients receive meals from like the senior site or the senior center. So you may see like people coming in and delivering meals on a daily basis. But we also have like a frozen meal program. So we have companies out there who ship like sometimes like 2 weeks worth of frozen meals. And so you might see individuals who get like a large shipment of frozen meals. We do have that service under this as well. Okay. And I want to leave just a couple questions. Does anybody have any questions just kind of as we're going along? Okay.
There's nothing
Ex
in the chat.
Nothing in the, okay. Thank you so much, Cheryl. Appreciate you. Okay, so expanded SPED. Expanded SPED is a little bit of a different program. In order to qualify, a person does have to be at least 65 years of age, or if they're under that age, they do have to be disabled through Social Security. So you have to kind of meet both of those components. This isn't the type of funding source that's for individuals who are like severely impaired in toileting, transferring, eating. That's more so going to be like your Medicaid state plan and your waiver services that we'll talk about in the next slides. But you do, in order to qualify, you do have to be impaired in three of these four IADLs. So meal prep, housework, meds, laundry. It's kind of a little bit more specific for this one. And we do sometimes have individuals too who maybe we fund adult foster care under SPED, and it's due to them having a health, welfare, safety need. For the purposes of this training, we don't necessarily need to get into that. This is a service that we're allowed to use if we have individuals who their functional impairment are due to mental health. So we are able to utilize this. Again, we don't want to use this service if the individual could qualify for a Medicaid service. So that's why it says here that we want to use waiver first. So you have to meet financial eligibility. This is for folks that are quite low income. So either they're on supplemental security income or the income they do have is at or under that max. And you can see here that's 967 a month. So it's designed to help those individuals who are very much in need. And you do have to be on Medicaid in order to access this service as well. Funding is state funded. It's actually not, it doesn't come from Medicaid, but Medicaid eligibility and being on Medicaid is one of the requirements. And then it's a lower level service. So it matches SPED in that it's about $4,000 a month. Services are almost exactly the same as SPED, so I'm not going to go too much into detail on here. Just kind of note that, eligibility is a little bit different, but services are very similar. Medicaid state plan we'll go into next here. So Medicaid state plan is really for personal care services like toileting, transferring, bathing, eating, those types of things. We can throw in a little bit of homemaker support in there, but this isn't for like those additional services. It's not for any supervision or oversight, just for personal care. So for our eligibility, we have like a three-tiered system. So it just really depends on like how much time you get, depends on how much time you need, right? How many activities of daily living you're impaired with or and how much time you need for those activities of daily living. So this can really range from somebody just needing bathing like once a week to somebody needing I think 7, 8 hours of care would be like the max every day. Um, so this just kind of talks a little bit about eligibility, but just know it's just for those personal care services. This is dependent on Medicaid. So an individual does have to be on Medicaid in order to access this service. And then we base things on units. So if you ever happen to talk to a case manager and they're talking about units or something like that in terms of the services, that's just a 15-minute increment of time. That's how we measure everything when it comes to our services. So if you think of like 480 units per month, that's like 480 15-minute increments per month of care that we can provide, and it goes up to 1,200 per month for Medicaid state plan. Again, case management is a service that's included in all of these funding sources. So just know that anybody who has any of these services has an HCBS case manager, and they're the ones authorizing these services for the individuals. We kind of talked about how we can add on some homemaker services here. Okay. Okay. So that's just for personal care. We're going to move on to waiver, which is kind of like our heavy hitter service, so to speak. This is kind of like our highest service level that we're able to offer. So functional eligibility for waiver, you do have to be 65 years or older, or you have to be deemed disabled by Social Security. So you for sure have to be at least 18. And so if you're under 65, you have to be at least 18 years old and you have to be disabled by Social Security. And you also have to meet nursing facility level of care. So our case managers do screening assessments where they input the information about that person's level of functioning. And really, what the waiver is designed to do is provide care to those individuals who like meet the level of needing to go to a nursing home, like the same level of care as a nursing home would provide, but they're choosing to receive the services in their home. So you can kind of understand that it's a little bit higher level of care. Again, this is more like for the physical impairments or maybe TBI, dementia. This is not a funding source we can utilize if the primary impairment is intellectual disability. We do have a DD waiver for that, and that's managed by the DD program or division, I should say. And also mental illness. This is not a service we can tap into if like that main reason for support is due to mental illness. So you do have to be on Medicaid for this service. We have a different kind of maximum for this particular service. So part of the waiver agreement that allows us to even have this in our state is that we have to certify that we're not spending more on our waiver participants than it would cost if they were living in a skilled nursing facility. So basically our monthly cost, we always have to stay under like the most expensive nursing facility in the state of North Dakota. And that can change. I think it changes every January. So we're always having to keep track of the different rates that the various nursing homes have in the state, making sure that we're remaining cost neutral wherever we can. Okay. So we have a variety of services under waiver, and some of these are all inclusive. So you may see individuals who have again, people coming in and out of their home every day, providing like some personal care services or maybe some supervision. But you may see individuals who have 24/7 care. And so there may be several, workers within that QSP agency coming in. They're providing overnight care to the individual. They're staying awake all night to provide care to that individual. And it's really all inclusive. So we have some services like that, like ResHab or community support where they're doing pretty much everything for that individual. They're taking them to their doctor's appointments, they're helping them maintain their Medicaid benefits, maybe they're helping to fill out like some housing paperwork benefits, things like that. They're doing medications. And it's really like we have some people who really aren't safe to be left alone. And so it's providing that all day continuous support. Or you may see blocks of time, like I said, with people coming in for a certain amount of hours, leaving, coming back. It really just depends on that person, what they're eligible for, what their needs are, but also what they're accepting of too. Because an individual does have to consent to all services and agree to their services and agree to their providers. So it really runs just a huge range in terms of like you might have one individual who's on like a very similar service and their hours are so entirely different than the other person's because it's all like customized for that individual. Um, so a lot of services on this, but I think kind of just letting you know that this is kind of like that higher level service. And like I said, there may be like several QSPs or qualified service providers coming in and out in a person's home to provide care to them. So, just want to quickly go over like this program comparison. This is something that's a little bit more technical. I don't know that you have to pay too much attention to this. This is like a cheat sheet that we utilize. Our case managers utilize this to kind of like put together the puzzle pieces of what an individual might be eligible for based on their income, based on their assets, based on whether they're on Medicaid, what service do they need, who do they live with, um, all of the information that they need to know in order to implement services. So I think I've said this word qualified service provider or QSP, but I didn't necessarily explain it too much. But these are the people actually doing the work. So we call them qualified service providers or QSPs. So like aging services, HCBS, where Annette and I work, we don't actually provide the care. Our case managers don't provide the care. They do the assessments and they authorize the care and then they monitor the care. So our qualified service providers are not employees of the state. They're actually independent contractors. So it could be an individual QSP who's just like a person, just like you and I, who's signed up to receive Medicaid payment to provide care for others in the community. It could be a family member who is caring for their loved one. Maybe they live with them and they have family personal care, family home care, or maybe they're an independent QSP and they come into that home and provide care. Or it may be an agency where it's actually like a business, like a structured business, and they're certified as a qualified service provider. And they might have many, many different individuals they serve throughout the community in different communities. We sometimes have qualified service providers who work for our aging and adult services, and they're also DD providers as well. So sometimes they kind of cross over to divisions. And so there may be, an individual within a home or apartment who receives DD services under one agency, and maybe there's another person across the street or on a floor down who receives different services under HCBS. So sometimes they do cross over. Um, an individual chooses their QSP. So just like Annette says, if they have a preference, it's their choice who provides care to them. If they don't have a preference, we provide, kind of a list of all our qualified service providers, and then we put and if they still don't have a preference, we push out the information to all the qualified service providers who are able to provide the type of care that individual needs. And then we make sure we're setting up the individual with the QSP who is approved and endorsed to provide the services that they need. They have the ability, they work in the area, that type of a thing. Um, It can be a little bit difficult in rural areas. Just depends on what the pool is like. So how many QSPs are in that area, are willing to serve that area, and what expertise they have. We do have kind of a higher concentration of QSPs in certain like bigger cities. And so for some individuals, it can be very easy to find a QSP. They kind of have their pick from multiple individuals, multiple agencies. And then in some of our rural, very low populated areas, there's not very many people who want to travel to that area, and there's nobody who lives in that area who is a QSP. And so they kind of have to piece different services together for that individual. Or sometimes individuals end up choosing to move to a different area where there are more service providers. But again, really, we're not choosing the QSPs for any of the individuals. We're giving them the information that they need in order to, determine who is out there, and then they're able to pick their choice of provider. Okay, so this is just kind of some information that we put on the screen. This is what we utilize, and this is what the public can utilize as well. It's just a search site. So this is where you can enter, a city, a zip code, the type of services you're looking for to be able to kind of find a list of different qualified service providers in that area who may be certified to provide that service for an individual. And then this is what Annette was talking about earlier when she said we have an ADRL resource link. So this is what we're able to use for referrals because we have a lot of individuals out there who may be eligible for services. And an individual themselves can contact the ADRL. A family member can contact the ADRL. Really, anybody can make a referral for someone as long as that someone is in agreement with the referral being made and knows the referral being made. But this is really kind of like that no wrong door approach, where you're able to contact this resource link and provide information about the individual, and then they will kind of filter through the different options for services. And a lot of times, those options for services are HCBS. And so this is kind of how you would go about linking somebody to these potential services if they're interested. Okay. So at the back of this PowerPoint, I always just leave a glossary because we talked about like different services. We talked about some acronyms, things like that, and it can be confusing in terms of like what are we talking about when we're talking about services. So these are just definitions taken from policy. So there's a few pages here that we go through and we just kind of list what we're talking about: emergency response system, environmental modification, family home care. So this is something you can kind of just thumb through if we mention something and not really sure what we were referencing or what that definition means. There's a gloss back here. And then we wanted to leave time for questions because we want to make sure that we're answering questions you might have or kind of like customizing the information we're giving you to make it more relatable for what you need to know and maybe what you don't need to know. So kind of open for conversations here.
And I was just going to add, a few things that just popped in my mind to maybe go over a little bit. So sometimes, we will get referrals where maybe a medical professional will say this person needs 24-hour care. You as if you're a landlord, you might think somebody should be with this person all of the time, but we really have to have kind of concrete information as to why that person needs somebody with them if they're eligible for it, even if a doctor has said that it would be beneficial for them to have somebody with them at all times. And then I wanted to also just say that we can't duplicate things that other community partners would be able to maybe provide. So let's say somebody is getting services for under DD, the intellectual disabled population. They can't also get services through us. Or somebody is working with the Human Service Center, getting skills training to learn, maybe how to do some homemaker things. We then also would not be able to duplicate that by providing that same type of service to them. And then I did just want to say that these are for people who need public pay assistance, right? there are, so many people who have resources, financial resources, but they don't know where to start. That ADRL number is the same place, and that they would call. And if they need help just navigating it, they would um, be assigned to a community service coordinator who is not under like our umbrella, but they're under aging services. And they can go out and help people navigate how do you go about getting services. Um, what we run into a lot is people who have resources don't necessarily want to pay for those services. And many times, even for us, if we go out and we can pay 80% and the person has a 20% share, they may decline, services. But the ADRL is where you could call, where do I find the nearest senior center site, and all types of things, because under the umbrella of adult and aging services, HCBS is just one part. The ombudsman is a part of our program. Adult protective services, which I know many people have worked with, and then the community support case managers that do more, the private pay individuals. So, for any questions, the ADRL would be the number to call. So anyway, I just wanted to add, those few things.
Yeah, I was also gonna point out too, that our HCBS case managers, like although they're very involved with monitoring the individuals, they have scheduled assessments. We have to see everybody at least every 6 months to verify continued eligibility, and they're there for a variety of resources. They try and hook individuals up with lots of different services, even those services that we don't authorize. But just as a reminder that the case managers aren't like first responders. So they're not working, evenings after 5. They're not working weekends, holidays, those types of things. And so they're not like maybe the first person you would call if there's an emergency, right? They're not going to be um, the person to contact. And so sometimes that gets confusing because you see like, well, there's providers in the home all the time, like there's somebody around, and it could be hard to get it mixed up with like your HCBS case manager or maybe like your housing coordinator or your MFP transition coordinator. But they're not kind of on call or anything like that. So just an FYI.
I would just add, things just keep popping up as we're talking, but um, if somebody has like a substance abuse concern, the case manager also, we can't really restrict. We can't say you can get this help in your home if you stop drinking, if you stop doing these things. So I think sometimes there is the idea that, oh, there's a social worker involved and they can make everything better. And we really wish we could always too, but we, aren't able to, mandate that people many times do what we might think is the best route for them. So. And
Yeah.
it may appear that maybe we're being unresponsive or we're not doing anything about a situation that should be better. But if somebody makes their own decisions, the case manager really does not have the authority to dictate to them some of those things. And I know that's hard for everybody who's working with that person.
Yep, we try and offer as much education, support, and options, as possible because we want to be supportive and, offer those resources. But sometimes it takes the individual taking that next step and, really wanting to take that next step. And so, that can be difficult. Can be difficult. Does anybody have any questions? Just, about more about what we do or services or anything like that that we want to review?
I'll, I'll throw out a question to get
Yeah,
people talking here.
sounds
What,
good.
what would be some of the things that a landlord should look for to make that call to ADRL? Is it all of a sudden they quit paying their rent or seeing confusion in the hallways or things like that. Do you guys want to talk about a couple scenarios of where you think that, hey, if you can call ADRL line and get the services started, that'd be great.
Yeah, I think, sometimes it's maybe like other neighbors or people in the individuals who maybe notice something. It could be you're noticing that maybe an individual appears very disheveled. Who knows? There can be so many different reasons why that could be an issue, right? But, maybe it appears that person is struggling a little bit physically. Maybe they're having a hard time, taking a shower by themselves, or maybe, you're noticing like clothing hasn't been washed, that type of thing. It appears maybe there's like a physical disability or age-related disability going on. Maybe they're struggling with keeping up on their laundry. Maybe they're struggling physically with keeping up on their housework. Maybe they're, um, you know, having a hard time cooking their meals, those types of things. But yes, sometimes, we'll get calls where a person seems really confused, they're up at all hours of the night, maybe it's an elderly individual who's living alone, or maybe it's an individual who has some sort of cognitive impairment through like a TBI or something like that. They're kind of noticing like maybe different behavior. We never want to be kind of a replacement for like, medical or emergency services, of course. But sometimes there can be kind of like those telltale signs that maybe a person isn't doing so well taking care of themselves. And it could be like other residents who are noticing some things going on, think, well, maybe they could utilize some help.
The other thing I would add to that is if you know somebody's been in the hospital, we get a lot of referrals from hospitals. But if you know somebody, has not been in their apartment, for a month, they've been in the hospital, they're coming home, and usually that referral should be made to us already. But if not, and you are seeing them or they're stopping by, the office or that type of thing, and I think it would be okay to say, hey, are you getting any help? How are you doing? Those types of things. Sometimes, if somebody calls who's from the building, whether it's a neighbor or somebody, we still do have to call the person to say, hey, we got this call and we're just wondering, how you're doing. Do you want some help? Sometimes they say no, but sometimes it is like they have not even thought of who could help them. That type of thing. Again, we do more of the chronic long-term physical disability. So somebody who, for instance, I guess went in for appendicitis and a surgery, we may not be able to help them because there is home health care and some of those things that cover that. But if somebody is been in the hospital and they seem to be needing anything, feel free to always call. When in doubt, call the ADRL and they can walk you through some situations. Or when it's time for inspection, sometimes that's when referrals come through like, oh, we went in to do the inspection and it's, really a mess and the person it appears maybe has a lot of incontinence or those kinds of things. So I guess I would recommend it, asking the person to or letting them know about our services. But either way you can call on their behalf as well.
Yeah, and there might be other resources too. And it can be really difficult because sometimes we have like a lot of different resources for individuals, but like they're still not paying their rent, or like they're still not paying their bills, and that's not really anything that we have a service for, right? We don't offer like any financial assistance or anything like that for that service. Or sometimes we do run across individuals who really like we'll get a call and there really is no functional impairment, like there really isn't a service need, but they just had an inspection and they want somebody to come in and like really get their place cleaned up. We're not always able to help with that. If an individual does qualify, they have a long-term service need, and that's kind of like not their only need. We've definitely been able to offer like chore services and things like that to kind of get get that deep cleaning type of thing done so it's more manageable and maintainable with ongoing homemaker services. But sometimes that's an issue. And for existing individuals, like we always try and, authorize everything we can. Our case managers try, if you're eligible for it and you can benefit from it, they're going to offer it to the individual. So
And, I'll just kind of add again that um, our services really are for people with physical disabilities or elderly, or it can be, a brain injury that occurred, dementia, but
mm,
to really the robust, services for people who have a mental illness, which I know can be some of the concerns that landlords deal with.
mm.
The human service centers really are more of the experts in that area.
I I do want to bring up pets because that may be like something of a concern for landlords, things like this. So our services, just to clarify, are for the person. We don't have any service array that provides like pet care. We don't have anything within our services that, takes like a pet out or cleans up after a pet, does anything pet related. So just to kind of, something to keep in mind. An individual really has to be able to care for their own pet unless they have like some informal support or maybe they pay privately, for somebody else to kind of assist with that. But in terms of HCBS and like what we're allowed to spend our federal and state dollars on, we're not allowed to do like chore for pet care. So sometimes that does become an issue if we have somebody and they get really excited about a pet, and I would too, like we're all animal lovers, but we find that they're just not able to take care of the pet and then, stains happen and messes happen and we're just not able to authorize our qualified service providers to take care of those types of things. So,
Okay, are there any more questions for the ladies? We've got one. What do
yeah.
people do for assistance for service dogs and
Yeah.
such? Who would you assist them?
Yeah, so like we're not able to provide any care for service animals either. So I kind of said pets, but what I should have said is animals. So we don't have any funding that gives us the authority to take care of like a service dog, take care of vet bills or anything like that. And so the individual would have to work out their own arrangement. Either, they're capable of taking care of that service animal or they have, another service, some informal family member support, or maybe a paid service, but um, I don't know of anything. I can't give any resources because I don't know of any like
Mhm.
assistance that an individual could get for that. Yep, yep. Like a guide dog for the blind, we're not able to provide any type of like assistance with animal care. That's a really good question though. That comes up quite often.
Yes, it
So appreciate
does.
the question. Yep.
Yeah. There seems, and there definitely are gaps. Another gap, in one is like the pet care, right? That we can't authorize, even if we would want to. Um, but the other one sometimes is unless you're at a really higher level service, that Christy talked about before, where you're, almost getting 24-hour care and they can take you to the doctor and things. Medical transportation is not something that we can provide under our services. It is something that can be provided under Medicaid, but the person kind of arranges that, has to arrange that themselves if they're under Medicaid. But that also is something that we can't provide under our funding sources.
Yeah. So common barriers people face when trying to qualify. I don't know that there's really a common barrier in terms of actually qualifying for the service, but we do see barriers in terms of like maintaining the service. And sometimes that can we see more complex cares. So, we see individuals who absolutely qualify for the program. We get them set up with service providers, but they may also happen to have, some sort of addiction, or they might also happen to have some sort of mental health struggle. And so, what can be hard is the way that that comes out in terms of service delivery. So if an individual is struggling, they're frequently very intoxicated, or maybe unfortunately they're involved in illegal substances. That's quite a big barrier because that prevents us from being able to ensure their safety and ensure the provider's safety as well. So that is something that it's hard to mitigate those risks and kind of overcome those barriers. And then also just people, just people working with different people. We run into individuals who can be a little bit difficult to work with. We may have individuals who don't necessarily treat their providers with respect. You've probably come across that as well. We deal with all kinds of individuals out in the world when we're working in the public. And so, we see issues of like sometimes verbal abuse, even sometimes physical abuse. And that can be a huge barrier because we're there to make sure that that individual is safe and that they receive the services they need in order to stay as independent as possible to try and prevent them from institutionalization if that's not their preference. But that could be very, very difficult if we have providers who don't feel safe providing care for them. Because QSPs get to choose who they provide care to. So just like individuals on services choose their provider, a provider chooses who they feel like they are capable of accepting and providing care to. And so I would say that's a pretty big struggle in terms of just really trying to make sure we're meeting the needs because we want to meet the needs of the people we have, not necessarily the people we want, right? We want to make sure that we're providing everybody who's eligible with services and supports that they need. So,
I would definitely agree with that. Again, a barrier, like we've mentioned, the rural areas, it is tough to get providers sometimes. Even some of the transitions that, if somebody wants to leave the nursing home and come back out to their home in this small community, we're always offering, hey, you could move to a bigger community because there's no providers. You need 24-hour care. So that can be a barrier. Sometimes, sometimes family influence isn't, it's by and large very, very good to have this family support, but sometimes it can be a barrier at times if that family member wants to be a provider, but that might not be the best choice type of a thing. But yeah, I think like Christy said it so well, whether you are older or physically disabled, like all of us, we all have different personalities, and sometimes people have a stronger personality that makes it hard for providers to want to provide. The other barrier I really think is because we see it all the time. I have to track all the referrals and how many open, and we only open about 50% of referrals that already have gone through this screening through the ADRL, so they're likely eligible. They come over to us. But when we go out and if they have a fee at all, many, many times they say no. So what happens, let's say somebody would be able to get a ride to the grocery store and go with shopping and get some cleaning and a bath 3 times a week. But they are going to pay 20%. The state's going to pay 80%. They may say no. And they maybe really can't afford it. Or they just, are saying no. And without those kind of entry level services, the person without that might decline faster or do something that might not be safe for them. They're cleaning and doing things and they have a fall, and then they may be in a facility and that cost is so much greater. So I think it's a barrier because it seems like that's the number one reason that people decline the services is if they have any cost share.
mhm. So Kevin asks in the chat, is continued substance abuse a condition for termination of HCBS services? How does HCBS address this? So potentially, depending on uh the legality of it, the safety of it. There's certain substances that are very, very dangerous to even be, in contact with. And so um, we have, two of us here, program administrators. We're constantly staffing situations with the case managers, right? And so we're providing technical assistance to them. We do a lot of risk mitigation. We do a lot of pre-planning. We have a lot of conversations. We have a lot of hard conversations and difficult conversations. And so it's a potential. We're pretty robust. And so we're kind of one of those services who, stays in and we try and do everything we can, but ultimately we do have to follow century code and administrative code. And there are some situations that rise to the degree of, really presenting a health, welfare, safety risk to individuals as well as the case managers who go in there because they're required to see individuals in person and the providers who provide that care. And so there may be times where you may know of an individual who was on services and their services did have to terminate. So to answer your question, it can rise to that level. Yes. Um, okay, so we have another question here. What happens to people when they have a hard time getting in-home services because of past issues in the home? And also when has a history with nursing homes in the past. Um, so really, we're looking at eligibility. And so, depending on the situation, I mean, we do sometimes have situations where the safety risk is too high and we do have to close services. But if it's something in the past, I guess we do fresh assessments every 6 months, right? And so we may have an individual who maybe was on services in the past, had a difficult time. Um, and maybe is applying for services again in the future and something has changed. We're gonna always go out and reassess that person if it's been 6 months and determine where they're at now, and determine how they're functioning now and determining kind of what the safety level is for them now, and kind of going from there. So sometimes we do have, maybe long-standing issues where there's still, a current situation going on that is something that we can't necessarily help them with. But again, we're assessing them at the point they're at, like right now, when the referral comes in. And so things change. We're not necessarily, it's like in-home services aren't necessarily similar to like maybe like a facility who, like, how do I say this? Um, like they're not able to admit or, they're not able to provide care. And maybe like there's several facilities throughout the state that aren't able to provide care. We kind of start from scratch when we're looking at the individual. But if there's issues that are still present, we do need to take those issues seriously because health is very health and safety is important. So I don't know if I answered that question correctly in
No,
terms of kind of how you meant to ask that, but
No, I think you did. And I would just add, for instance, we at times do close cases for health, welfare, safety. The person is issued, they have a denial, a citation, they have the right to appeal, all of that. But for instance, if somebody has been found, they're using meth and fentanyl in their home, we will likely have to close that case. Now, if 3 months goes by and they call and want to apply again, and it's before that 6 months, the intake, would talk with the supervisor who's out in the field, who would call that person to say, have you gone through treatment? What has changed? Because, we do have to, in those situations, look at the risk to case managers and other providers. Sometimes if it's behavioral, um, somebody's been aggressive with providers, and nothing really has changed. Maybe we've transitioned this person 2 or 3 times already, and it has not worked either. Maybe their medical needs are too great for what we can do because we are not like hospital. We're not home health care. We are more for chronically like needing assistance with those ADLs and IDLs. So sometimes we will look at it like, okay, we are going in with a fresh set of eyes because it's been 6 months, we're going to meet. But if a repeated situation has occurred and it does cause a safety risk to others or the person, themselves, that is a factor. And the case managers always have to staff those situations. They really can't make that decision on their own. So sometimes, we'll hear, well, this person got these services. This person over here is exactly the same, but they're not getting those services or they didn't get a chance. But just to let you know that those are really not up to that individual case manager, that we staff a lot of those situations. And if somebody is denied services, they are given that legal right to appeal and they can do that. So, and that just when Christy was going through, we have maybe 20 different services, 4 different funding sources. It truly is like a puzzle when that case manager goes out there to see what are they eligible for? What do they want? Do they live alone or not? Piecing this together. And so from the outside, it may look like this person is the same as this person, and this person over here is getting all of this, and this other person isn't. But to just know that there is a lot that goes into that assessment and eligibility, and without a release, that case manager likely can't, disclose any of that information. So. And we serve so like I said, we have 64 case managers, and then we have another 11 that are part-time. And so, but we serve about 3,200 individuals across the state. And then we have 4 basic care case managers that serve about 700 individuals who live in a basic care facility, which is kind of a lesser degree of case management. But we are serving a lot of people, and we get about 150 to 170 referrals every month, and about half of them open. So we're moving fast, but the good that we can do, I think in a lot of situations, we really can make a difference. So if you are questioning whether you should call and make a referral, it just doesn't hurt to do that. They might not be eligible, or they may not want the service, but they might be.
Yeah, I think we're at time here, Cheryl.
Yeah.
So
Well, thank you, everybody, for joining us today for the Tuesday training. And thank you, Annette and Christy, for sharing all the information with us. It's a great presentation, and we appreciate you. So have a good
thanks.
afternoon, everyone.
Okay.
Bye.